Clinical Virology Part 2. So we're going to continue by talking about some additional double-stranded DNA viruses. Human papillomaviruses. These are the causes of warts. They're clustered into 5 genera. Most clinically significant HPVs are in this genre. Alpha papillomavirus includes types infecting the genital and non-genital mucosa, genital and cutaneous surfaces. Types most often seen in human cancers, like cervical cancer. More than 100 types of these small double-stranded DNA viruses. More than 40 types are sexually transmitted, known as the genital types. Here you can see cutaneous and mucosal, the different types that exist, and whether they have an association with malignancy. And when we talk about malignancy in human papillomaviruses, we're not just talking about cervical cancer. This type of virus, certain strains of this type of virus, can cause anal cancer and oral cancer. So it can cause cancers of inside the throat or inside of the anus and rectum. Cervical HPV lesions are flat areas of dysplasia or abnormal growth, and they're often difficult to see. Wart formations, though, are very easily identified. Removal of the lesions by surgery or cryotherapy or laser is recommended for warts. Typically, once you remove the warts, they don't come back. In severe infections, or if they don't get deep enough into the root of the wart, they may grow back, but if you cut around it and deep enough, usually it goes away. Diagnosis, so HPVs cannot be grown in cell cultures. Laboratory diagnosis often involves cytology sections, smeared examined by cytotechnologists and cytopathologists. Other testing include nucleic acid probe tests and PCR. As many as 1/3 of all college-age women are infected with HPV, and most develop only subclinical infections. Because finding HPV in cervical tissue is not the sole predictor of invasive disease, there's some debate about whether it's useful to look routinely for the virus in cervical specimens. Vaccines, there's Gardasil. That's a vaccine that's recommended, and it's recommended for males and females, ages 9 to 26. They assume after age 26 that you've already been exposed and infected. Typically, once you get infected with one type of HPV, you don't get infected with another type. So if you happen to get infected with one of the asymptomatic types, then that protects you from getting infected with one of the other types that may cause genital warts or may cause different types of cancer. But either way, they recommend that before anyone becomes sexually active, that they get vaccinated, and it's usually a series of 3 vaccines that are taken about 6 months apart. Second vaccine against HPV type 16 and 18, Cerevix, is approved for use in women in 2009. HPV type 16 and 18 are linked to most cervical cancers and other HPV-associated cancers. Controversy exists about the use of these vaccines because it's recommended that they be administered at a young age, preferably before sexual activity. So just want to walk down the cervical cancer scheme. So from some personal experience, cervical cancer. So typically, if you're a woman, you go get a pap smear, and the pap smear is going to be evaluated by cytology, and it's going to look for the presence of abnormal cells. If you see an abnormal cell shape in the pap smear, then the next step would be to order a biopsy. And the biopsy that happens next is going to be done with like local injection of local anesthesia, and then the biopsy procedure is performed. A little bit of bleeding after the biopsy, and then the biopsy is evaluated for the extent of the depth that the abnormal cells go into. So if they see that the abnormal cells are just at the surface, then they kind of just monitor it, and they ask you to come back for more frequent pap smears, and they just kind of monitor the development of it. Typically, once they see abnormal cells, it takes many, many years for these cells to actually develop into a cancer-like lesion. But sometimes women don't go frequently to the gynecologist or don't get routinely evaluated with a pap smear, so it can go undetected. So then you go back, and if the biopsy did go deeper into the tissue, then they recommend a LEEP procedure, so laser electrosurgical excision procedure. And that just means that they're going to take a laser and remove a large chunk of the affected area. So there's a certain type of solution that they can spray on the cervix, which is going to cause the cancer or abnormal cells to take on a white, dusty appearance. And then the physician knows how much to remove of the cervix. So in my case, it was cervical cancer at the first level, so it wasn't super scary. It didn't disseminate or spread anywhere. So they were able to remove it, but they did have to remove a huge chunk of my cervix. And I was told back in 2008 when this all happened that I would never be able to have children. Fast forward, I have 2 children. So the cervix has this amazing ability to regenerate and grow back. So that's exactly what happened. And I was able to have kids, no problem. I have since tested negative for any type of abnormal pap smears, so now I'm on the regular cycle for every 3 years. But super scary that it developed into that, and it was honestly my own fault because I went several years without getting tested. So highly recommend that whatever your age, that you, if you're a woman, you continuously go get those pap smears and get those evaluated. If you're vaccinated, there is still a chance that you could develop cancer. It's just extremely low. Just like any vaccine, vaccines are not 100% effective, but they're pretty strongly affected. So if a male gets the vaccine, and they're less likely to transmit it to other individuals. And males themselves have been associated with the oral cancer and anal cancer. So it's just a good idea to get everybody vaccinated. Pox viruses are amongst the largest of all viruses, possesses characteristics brick-shaped and contain double-stranded DNA genome. Causative agent of smallpox, which infects humans only. It is a bioterrorism agent, so most of our military get vaccinated against smallpox. It was eradicated. It's extinct in nature. After decades of aggressive efforts toward vaccination, education, and eradication, the World Health Organization officially declared it the world smallpox-free in May of 1980. One culture is kept at the U.S. CDC and one remains in Russia. Again, significant concern, bioterrorism. So that's a picture of it. Smallpox characterized as synchronous progressive rash accompanied by fever, 10 to 17 day incubation period, disease progression, fever and oral lesions can appear. Patient is infectious. Faint macular rash develops on all parts of the body within 24 to 48 hours. Centrifugal distribution, lesions are in greater concentration on the head and limbs, include the palms and soles. Macular rash progresses into papules and vesicles and finally pustules. The pustules are deeply embedded into the tissues and all lesion changes occur at the same time, hence the term synchronous. Mortality rate was on average 30%. Other forms of smallpox, flat and hemorrhagic, occurred rarely and were almost always fatal. Vaccinations, routine vaccination ended in 1972, but 2 vaccines are approved for use in the U.S. Although smallpox was eradicated with the use of a relatively safe vaccine, most of today's population is now susceptible to infection because vaccine is thought to only have protection for up to 10 years. Because humans are now susceptible to variola virus, it remains a threat as bioterrorism weapon. Most military personnel moving into areas of conflict receive the vaccine, as I mentioned. If an outbreak of smallpox were to occur, there's sufficient stock of smallpox vaccine to mount an effective vaccination program in the United States. The antiviral compounds Cytofovir and Brincidofovir have been shown to be effective in combating the disease in humans. Monkeypox, first described in primates in 1958. 1970 was the first human monkeypox case. 2003, there's a multi-state outbreak that occurred. It's thought that monkeypox traveled from Africa to the United States by imported rodents. Human infections are rare, vesicular pustular febrile illness like that of smallpox, less severe and significantly lower mortality rates. In 2022, an outbreak of monkeypox occurred in 50 countries. World Health Organization reported 3,413 laboratory-confirmed cases and 1 death between January and June of 2022. 86% of cases were reported in the European region, 460 cases in the United States. One theory, the virus might have been circulating below detectable levels and maintained human-to-human transmission for a period of time. Vaccination provides some degree of protection. There has been a concerning rise in the number of cases of monkeypox infection in non-endemic areas in recent years. Indicates a weakening of protective immunity or emergence of mutant strains that are not protected by the smallpox vaccine. Single-stranded DNA, ssDNA viruses. These are parvoviruses or parvoviridae, smallest of the DNA viruses. The principal human pathogen, parvovirus B19, classified in the genus Erythrovirus, virus named after the serum sample number 19 of panel B, in which the initial viral isolate was observed. Infections range from asymptomatic to potentially fatal. The most recognized syndrome is erythema infectiosum, more commonly referred to as fifth disease. Symptoms of fifth disease: prodrome of fever, headache, malaise, myalgia, followed by respiratory and GI symptoms, nausea and vomiting. The prodromal phase lasts a few weeks, after which a rash often appears. The rash gives a slapped cheek appearance and then spreads to the trunk and limbs. Other symptoms: arthritis or joint pain. Most infections occur in children and adolescents. 80% of adults are seropositive by age 65. The virus can cause transient aplastic crisis, self-limiting erythropoietic arrest, decrease in red blood cell production in bone marrow. Complications are listed below. Within about a week, reticulocytosis occurs and the patient recovers. Persons with weakened immune systems caused by HIV infection, organ transplant, cancer, or leukemia are at risk for serious complications from fifth disease. Creates risk for fetuses and blood transmission in blood products. Another note about parvovirus: parvovirus is a lot more serious of a concern in dogs. So there's the dog parvovirus, which parvovirus is all over the soil. Dogs tend to pick that up. They can even get it from their mothers. If the mom's laying down in the soil and stands up and lays back down to nurse the babies, then the babies can get it. It's recommended that all puppies get vaccinated against parvovirus. If not, puppies can die. So, personal case of parvovirus: I was living in Texas getting my first master's degree, and I could not afford the care for all of these puppies that were recently born on my ranch, and it was completely unexpected. I did not know that the mom was by a male dog that had not been fixed, and all of a sudden I started noticing her getting a little bit fatter and fatter and fatter, and eventually she had her pups. So we had the pups outside, couldn't afford to vaccinate them, and unfortunately one of them developed severe symptoms. So I brought her in the house. These were outdoor dogs. In a ranch in Texas, you usually just have like a huge fenced in like area and let them roam free. So they were outdoor dogs that lived in the barns and stuff. So this puppy, I brought her inside, and she was literally vomiting, and diarrhea was coming out of both ends. It was really difficult to keep her hydrated. So I went and got her medical attention at the local vet. The vet gave me vaccines for all of the puppies, and I vaccinated all of them, and they all ended up not getting the symptoms like she did. And even though symptoms had began, he did recommend that I give her the vaccine. So we vaccinated her, and she ended up living. But it was a really scary couple of days, and dogs typically have a high mortality rate once they start to show symptoms of this. But a lot of intense supportive care, and I managed to get her through that. Human bocavirus, a novel parvovirus described in 2005. Clinical symptoms: cough, rhinorrhea, fever, difficulty breathing, diarrhea, conjunctivitis, and rash, primarily in the winter months. Detection of HBOV has improved with the development of sensitive and specific real-time PCR assays. All right, moving on to double-stranded RNA viruses. Naked double-stranded RNA viruses have two protein layers surrounding the capsid. Most common cause of gastroenteritis in rotavirus, most common cause of gastroenteritis in infants and children. You've probably heard of rotavirus quite a bit. There's a lot of outbreaks of rotavirus and a lot of people reporting cases of rotavirus. I would say rotavirus and norovirus are the two most commonly associated with what we would call stomach flu. But we know it's not a flu, it's not an influenza, but it is a viral infection. So rotavirus is one of the common ones. Gastroenteritis is a major cause of infant death and failure to thrive. Most outbreaks occur in winter months in temperate zones and year-round in subtropical and tropical regions. Route of transmission: fecal-oral route within 1 to 4 days. Incubation period. Symptoms typically occur suddenly. Vomiting, diarrhea, fever, often abdominal pain, and respiratory symptoms can lead to fatal dehydration. Virus multiplies in the epithelial cells in the tips of the small intestine microvilli. Microvilli are stunted and absorption is reduced. The virus is shed in large quantities in the stool and can cause healthcare-associated outbreaks in the absence of good hygiene. Diagnosis. Although rotavirus is present in large numbers in the feces, it can be isolated only with special procedures. So we use immunological procedures to evaluate it. Electron microscopy can be used, however, it's not very sensitive. There is a vaccine that's available. A second vaccine is also approved. Both vaccines were shown to be safe and effective, so it's a good idea to get kids vaccinated. Single-stranded RNA ssRNA viruses. Arenaviridae, arena meaning sand. Under electron microscope, the virus appears sandy and granular. Members of arenaviruses are commonly divided into two groups, the Old World and New World complexes. Mode of transmission is via contact with aerosolized virus or fomite contact with infected rodents. The most well-known member is the Lassa virus, associated with lymphocytic choriomeningitis. Symptoms: most exposed individuals develop asymptomatic infection. Some develop fever, headache, pharyngitis, myalgia, diarrhea, and vomiting. Severe symptoms may occur: pleural effusions, hypotension, hemorrhaging, CNS involvement, and seizures. Encephalopathy. Transmission: community-acquired, hospital-acquired, airline travel by people from endemic areas. A resurgence in the infection in Nigeria prompted vaccine development efforts. Diagnosis: serological diagnosis is recommended. Real-time PCR: virus is present in throat secretions. Treatment: if therapy is begun within the first 6 days of exposure, Lassa virus infection can be effectively treated with the antiviral drug ribavirin. Bunyaviridae, member of the group arboviruses. Viruses replicate internally in the gut of the arthropod vector when feeding. Mode of transmission: the arthropod, which is an insect, transmits the virus when feeding on a blood of the vertebrate hosts, including humans. Asymptomatic viremia develops after a few days. While much less common, some hosts become febrile. Most virus members can cause febrile illness, hemorrhagic fever, or encephalitis. The lacrosse virus, reportable disease, can present as encephalitis. Incidence is underestimated because the disease manifests as a nonspecific fever, headache, nausea, vomiting, and lethargy. Commonly occurs in children in the summer, called summer flu or summer cold. Diagnosis: serological tests are not offered, and disease has very low mortality. Definitive diagnosis is not often made. So this is one of those cases where kid's sick, oh, it looks like a virus, and they get sent home with no treatment and no diagnosis. Hantaviruses, also known as the New World hantavirus, the Gina hantavirus, Hantan virus, Sol virus, Pneumol virus, and Debra virus, do not infect arthropod hosts. They're rodent-borne viruses. The transmission: inhalation of contaminated aerosolized infected rodent urine, saliva, and droppings. Causative agent of hemorrhagic fever with renal syndrome. Distribution varies by specific virus. Disease targets the kidneys. So with hantavirus freaks me out because if you happen to be sweeping a barn where a certain type of rodent lives, it's a type of mouse, and the mouse is infected, the mice will shed this virus in its feces and its urine. So as you're sweeping up barns or you're sweeping areas or maybe even camping, like there was a big outbreak or not big outbreak, I think it was only like 4 individuals, but there was like a significant outbreak where 4 people died suddenly after getting exposed. And then there was recently a couple famous people that ended up dying suddenly because of exposure to hantavirus. So if you happen to inhale the viral particles, it takes a very small amount of viral particles to cause an overwhelming infection, and that infection is highly fatal. So this one is something to make a note of. Clinical manifestations affect peritoneal cavity, thoracic cavity, kidneys, or lungs. 3 to 5 day febrile prodrome with fever, chills, and myalgia. Patients enter a phase of fever and shock accompanied by oliguria. As the patient recovers, the kidneys gradually regain function. Mortality rate for HERFs is 1 to 15%, but these can get really significant really quickly. Sin nombre virus, so that's without a name virus, first described in 1993, and sin nombre in Spanish is without a name. The disease caused by this virus was named hantavirus pulmonary syndrome. The virus is transmitted through inhalation of contaminated aerosolized mouse urine, saliva, and feces, not known to be transmitted person to person. Clinical manifestations of hantavirus pulmonary syndrome: 3 to 5 febrile prodrome. Patients then enter a phase of hypotensive shock and pulmonary edema. Patient develops tachycardia, hypoxia, and hypotension. In severe cases, DIC can develop. Mortality rate is about 50%. Treatment is primarily supportive. Diagnosis of hantavirus infection: no FDA-approved laboratory tests. Some European tests are being evaluated. State health labs and the CDC perform antibody tests. Immunohistochemistry is a sensitive method used to detect hantavirus antigens. Norovirus. This is the most common cause of infectious gastroenteritis in the United States. Causes 19 to 21 million cases a year with 900 deaths. Most deaths are in patients aged 65 or older. They cause outbreaks of acute gastroenteritis in schools, colleges, nursing homes, and families, as well as on cruise ships and resort areas. The virus can be found in drinking water, swimming areas, and contaminated food. Transmission is most commonly foodborne, although waterborne and person-to-person transmission can be significant. Disease progression: incubation period 24 to 48 hours. The onset of severe nausea, vomiting, diarrhea, low-grade fever is abrupt. Infection rate can be as high as 50%. Illness usually subsides within 72 hours. Immunity likely shortly lived. Multiple infections are possible. So there's an electron micrograph picture of it. It can't be grown in cell cultures, so real-time PCR is now the most useful diagnostic assay for detecting norovirus. Several immunological tests are available. And coronavirus, so the coronaviruses. 30 recognized species of coronaviruses. 6 are found in humans. 4 strains are considered endemic in the United States. Associated with upper respiratory tract infections, some can infect more than one related species. One strain has been linked to croup in children, responsible for 15% of cold-like infections seen in adults. Higher conversion rates are seen in children. A few coronaviruses are responsible for a small percentage of pediatric diarrhea cases. In general, the illness lasts about a week and blood may appear in the stool. They have a linear positive strand RNA genome. They were first identified by electron microscopy and were named because of the distinctive club-shaped projections on their surface that resemble a crown. So that's a picture of coronavirus. A novel coronavirus was the causative agent of a pandemic respiratory disease that emerged from Hong Kong in the late 2002. This was SARS. So symptoms: high-grade fever, pneumonia, and in some patients, acute respiratory distress syndrome, SARS. Causative agents: SARS-associated CoV or COVID, SARS-CoV. Other outbreaks: 2012, there was MERS, the Middle East Respiratory Syndrome. 2002, that's SARS outbreaks, which sparked interest in epidemiology, reservoir-host relationship, and vaccination possibilities. And 2019, pneumonia with unknown etiology, reported to the World Health Organization by national authorities in China, first seen in Wuhan, China, and was thought to have emerged in a food market. The virus was officially identified by Coronavirus Study Group as SARS-CoV-2. The disease is coronavirus disease COVID-19. Clinical manifestations of SARS-CoV-2: highly infectious, and although most individuals are asymptomatic or have mild symptoms, those with certain medical conditions often progress to severe life-threatening illness. Risk factors include diabetes, overweight or obesity, history of smoking or cancer, and heart and kidney disease. Severe illness is linked to 2 primary causes: secondary pneumonia and overexuberant pro-inflammatory cytokine response. The cytokine response is referred to as a cytokine storm or hyperinflammation. The cytokine storm syndrome is uncontrolled activation and amplification of the host immune response. It results in the release of several cytokines and appears to be related to the severity of ARDS, so widespread inflammation in the lungs. Acute respiratory distress syndrome. It targets epithelial cells of the respiratory tract. It is transmitted from person to person via direct contact or airborne routes. Other affected organ systems: spleen, lymph nodes, digestive tract, urogenital tract, CNS, bone marrow, and heart. Virus can be isolated from urine and feces, so it suggests other routes of transmission. Diagnosis: coronaviruses are extremely fragile and difficult to culture, so the preferred detection method is PCR. There are antibody tests available, but antibody tests don't seem to be as effective as PCR. Treatment: basic life support, mitigating the effects of the respiratory symptom caused by ARDS, the leading cause of mortality. Modulating cytokine levels is key in preventing widespread organ damage, respiratory failure, and death. Drugs with anti-inflammatory activity are listed here, and then convalescent plasma was also used. So, telling you a little bit of a story from my experience with COVID-19. Both of my parents got infected with COVID-19. We believe that my dad acquired it from someone that he worked with, and when he was at work, the person was wearing a mask, and he was wearing a mask, but somehow the masks were not effective, so my dad ended up getting sick. My dad started with flu-like symptoms, felt extremely sick pretty quickly, but never developed the inability to taste or smell. It seemed to be, like back then when this was all developing, it seemed to be that the individuals who lost the sense of taste and smell tended to have milder symptoms than the ones who did not. So he continued to be able to taste and smell his food, no sensory disruptions, but had severe inability and inflammation in his lungs and inability to breathe. And that eventually landed him in the hospital. So he was gasping for air. I got a phone call in the middle of the night that he had to be transported. So I raced over there. All of the paramedics that were there were in full respiratory protection. So they had like big body suits on and respirators on. And when they transported him, basically my dad, who's a pretty tough guy, said goodbye. He genuinely thought he was going to die. He couldn't breathe at all. He was gasping for air. They got him to the hospital, and it was, because it was all locked down, nobody was allowed to visit him. I would get occasional contacts from his treatment personnel, and then he was able to text me some updates of how he was doing. So this was before the vaccine was developed. So he was in like the first round of people that got infected, and they ended up finding some convalescent plasma for him. So convalescent plasma came from people who previously had the infection and had developed antibodies against it. Now, it took some time before they started doing this treatment, and my dad's blood type is a pretty rare blood type, so they had to find the correct type of convalescent plasma for him. They finally were able to ship it in within a few days, and my dad said within about 8 hours of receiving the convalescent plasma, he could breathe again on his own. They never had to go to the point of putting a respirator on him, and it was noted that when patients did receive a respirator, they had a higher mortality rate. So the respirator itself increased the inflammation in the lungs to the point where people ended up having a higher mortality rate. So the treatment was not a great option. So this convalescent plasma was amazing for him, and he ended up starting to get a little bit better at 8 hours after receiving it. Now, meanwhile, day 2 that my dad was in the hospital, I get a phone call from my mom. My mom's screaming at the top of her lungs. And she had severe back pain. She thought she was having a heart attack, and she was screaming and freaking out. I've never heard my mom scream in that way. She said the pain was just unimaginable, and she couldn't handle it. So I drove over to my parents' house, and I was not allowed to enter the house because I knew they were infected with COVID, but I was watching my mom pace around in the living room, and I was standing in her front yard. I made the call to call 911. I said, that's it, she's got to go in. Now, my mom had recently had knee surgery, and during the knee surgery is when she got COVID. So she was recovering from her knee surgery operation, and then she basically got COVID, and her symptoms were a little bit less severe than my dad's. she was really tired and she didn't really want to stand up or walk around. Well, knowing what I know about the body, if you have surgery, you got to keep blood flowing in the legs. So she got sick and didn't want to move, so she eventually just um, sat around a lot, which promoted the development of blood clots in her legs. Now, she didn't know it at the time, and I genuinely didn't think about it at the time, but they transported her to the hospital. And on her way to the hospital, I'm running through every possible scenario in my mind. And I called the doctor and I was like, my mom just had knee surgery. Check her for clots. I need you to check her D-dimer level, check her for clots. I think she's having a pulmonary embolism. And the doctor kind of laughed it off and said, no, typically patients have a lot of extreme pain in their lungs and in their chest when they have COVID. So this is just COVID pain. And I said, no, it's not. I know my mother, and I insisted that they test for blood clots. Sure enough, came back positive. So she had pulmonary emboli. Her right lung had a massive clot in it, and her left lung had 10 smaller clots in it. So both of her lungs were infiltrated with clots, and that was what was causing the severe pain. So they started her on anticoagulants right away, and she stayed on those for about 6 months after the clots had cleared. But that was kind of the perception at that point, that, the fact that COVID was present made doctors forget about all of the other medical school stuff that they had learned. Also, there was a high association between clots and COVID regardless. So whether or not my mom had a surgery or not, that should have been a consideration, but they didn't think of it. So when it came back positive, my mom said that the doctor came in and asked if her daughter was a medical doctor. So that kind of made me feel good. She's like, no, she's not a medical doctor. She teaches nurses and healthcare professionals how to do their job. So I, to this day, tell my mom that I saved her life. But all joking aside, really scary time in my life when both of my parents suddenly ended up getting this infection, and I could have lost both of my parents. So super scary time. As soon as the vaccine became available, we all got vaccinated, and got the boosters and all that kind of good stuff. All right, filoviridae, only two discussed here: Lake Victorian Margo virus or MARV and Ebola virus, EBOV. These viruses share common morphology and similar genome and structural proteins. They have many similarities. They rarely cause human infections. They cause infections with high mortality rates, and they have unknown reservoirs in nature, although human infection can result from contact with infected monkeys. Clinical manifestations of MARV and EBOV produces hemorrhagic fever, incubation period 4 to 16 days, sudden onset of fever, chills, myalgia, and anorexia. Symptoms: sore throat, abdominal pain, diarrhea, vomiting, and maculopapular rash. Bleeding from injection sites and GI tract. Hemorrhaging in the skin and internal organs may also occur. Diagnosis: because of the risk of laboratory infection, biosafety level 3 laboratories are required. Sometimes electron microscopy can work. Newer molecular testing is being developed. And this is what Ebola virus looks like. Japanese encephalitis virus, or JE virus. Major cause of encephalitis in Asia. The most common cause of arbovirus encephalitis in the world. Most patients are asymptomatic. Cases are likely underreported. Children are most affected by this infection, with mortality as high as 30%. Mortality in adults is much lower. Dengue virus, responsible for two different diseases: dengue fever and dengue hemorrhagic fever. Deaths occur in children younger than 5 years in association with dengue hemorrhagic fever, and it's transmitted by Aedes mosquitoes. Dengue fever, headache, myalgia, bone pain, resulting in the nickname breakbone fever. Some patients develop a rash. Self-limiting, often resolves in 1 to 2 weeks. Dengue hemorrhagic fever, patients develop DHF after previous exposure to one serotype of dengue virus, and are then exposed to one of the other 3 serotypes. Exposure to 2 different serotypes of dengue virus appears to be necessary for the development of DHF. Patients with DHF develop the symptoms of classic DF, along with thrombocytopenia, hemorrhage, shock, and sometimes death. Yellow fever is caused by the yellow fever virus, considered an emerging pathogen even though a vaccination has been available for decades. The actual incidence may be underreported, still endemic in parts of Africa and South America. 80% of these populations must be vaccinated to reduce the impact of disease. So, why aren't they getting vaccinated? It's not only the lack of medical care or access, it's certain cultures do not believe in vaccination, and certain cultures believe that if you get vaccinated against anything, it can cause impotence, it can cause men to lose their ability to have offspring, and there's all sorts of crazy theories out there. So, there is a cultural war against certain types of vaccinations where medical professionals try to go to those areas and bring the vaccinations, and they end up getting their life at risk. They get shot at, and all sorts of crazy things happen. So if a person is planning on traveling to endemic areas, it's recommended that they get vaccinated. So that's one of the series of vaccines. I know when I traveled to Kenya, I had to get the yellow fever vaccine and I had to get the dengue fever vaccine, both of which made me ridiculously sick after getting those vaccines. But yeah, if you're going to travel to an endemic area, it's recommended. Symptoms: asymptomatic or acute infection, flu-like symptoms. Systemic toxic phase in about 15% of patients. Fever, jaundice, hemorrhaging from the mouth, eyes, nose, stomach, and other areas. Kidney failure can cause 50% mortality rate. St. Louis encephalitis, or SLE. Symptoms usually asymptomatic, fever only. Some patients develop meningoencephalitis, milder in children than adults. Mortality 3 to 20% in symptomatic patients. Transmitted to humans by the bird-biting Culex mosquitoes. Most often occurs in the summer months. West Nile virus. Birds are the natural hosts. Transmission is mosquitoes. Humans are the dead-end hosts. Symptoms usually asymptomatic. West Nile fever, if symptomatic, general flu-like symptoms. Some patients develop meningitis or encephalitis, particularly adults over age 50. Excuse me. Diagnosis: rapid ELISA, indirect immunofluorescent assays for antibodies. Several real-time PCR, TACMAN, and nucleic acid sequence-based amplification assays have been used. There's no specific treatment for the infection. In severe cases requiring hospitalization, supportive care is provided. Zika virus. This is a mosquito-transmitted virus that can be transmitted via infected blood or sexual contact. Endemic in areas of Africa and Asia. Significant number of cases reported across South, Central, and North Americas. Symptoms: fever, headache, microcephaly in newborns during an epidemic in Brazil between 2014 and 2016. Microcephaly is when the baby is born with a smaller than usual head. Influenza viruses. These are enveloped. Members can be distinguished by two major structural proteins, the matrix protein and the nucleoprotein. Worldwide distribution. Originated as zoonotic infections carried by different species of birds and mammals. Influenza season: the southern hemisphere is May to October, northern hemisphere is November to April. Segmented genome, and types A and B have 8 segments, C and D have 7 segments. So starting with type A, this remains one of the most crucial health problems worldwide, classified into subtypes using 2 major surface glycoproteins, hemagglutinin and neuraminidase. This is highlighted because it's super important that you know what the H and the N stand for. The H antigen is used to bind host cells, and the N antigen cleaves budding viruses from the infected cells. Key to persistence of influenza virus is its antigenic variation. Each year, antigenic drifts occur caused by RNA replication errors in the virus. Antigenic variation drifts occur with all 4 influenza types. When surface antigens change drastically, an antigenic shift occurs, resulting in new antigen, either H or N. Antigenic shift is only associated with influenza A. Notable influenza A antigenic shifts. H1N1 was the Spanish flu back in 1918 to 1919. H2N2 was the Asian flu in 1957 to 58. H3N2 1968 was the Hong Kong flu. H5N1 1998 the avian flu. H3N2V, mixture of avian swine, and human viruses in 2011. And H1N1 was the swine flu in 2009. So I happen to be working in the clinical lab at Aurora West Dallas Medical Center. It used to not be called Aurora West Dallas Medical Center back when I was working there. It was just West Dallas Memorial Hospital. So in the hospital, I was a specimen processor. So I was the person that was entering in all the orders. And back then, we used to get paper copies of the orders. So the paper would be tucked into a bag with the specimen, and then I would be the person that would transcribe all of the written orders into the computer database to ensure that the correct orders were ordered on each one of the tests. And then I would also test or look for specimen integrity, and I would be the one calling in case the incorrect specimen was received or specimen integrity was compromised, if the transport time was too long, all those kinds of things. So a lot of upfront pre-analytical work that I performed, and then some basic testing that I did at the various benches. All of the stuff that could be performed, like CLIA wave tests and all that kind of stuff, could be performed by a nurse or non-laboratory professional. So when swine flu hit, all of a sudden there was a mass rush of specimens. So all of our normal testing was now clogged by all of these people who thought they had swine flu. And even if they had a mild cold, they insisted on getting tested. So we were receiving thousands and thousands of additional specimens that weren't previously an issue. So a lot of our primary care shifted to swine flu testing, and that caused a lot of issues and disruptions. And even though swine flu, it was an outbreak, it caused a significant amount of infections. It wasn't as serious as people made it out to be. The bigger problem with the swine flu epidemic is the primary care was kind of paused. So all of the typical testing that we would have done was all delayed, and that sometimes led to increased mortality rates in people because we shifted our focus to do all this swine flu testing. So clinical manifestations, influenza viruses are spread through aerosol inhalation. I'm not going to talk too much about the details of these. So A and B have pretty much similar symptoms with cold-like symptoms, they're general respiratory flu-like symptoms. Influenza C can cause mild upper respiratory tract infections in humans, which is indistinguishable from the common cold. Influenza D was isolated from a pig in Oklahoma in 2011. Subsequently, it's been isolated from other animals, but little's known about the likelihood to cause human infections. Specimens would be nasopharyngeal swabs, washes, or aspirates collected early in the infection. There are a lot of rapid kits and over-the-counter kits that are available. A lot of immunological tests and nucleic acid-based tests are common. Vaccines, it's highly recommended that because there's that antigenic shift with the H's and the N's every year, that a person gets vaccinated every year. And when they do get vaccinated, they get vaccinated with the 3 most probable types that we think is going to be coming around the next year. So virologists study the trends of how these viruses have been mutating in years past. They make a prediction, a very educated guess of what the next strain of virus is going to be circulating, and then they vaccinate you against the 3 most common that they think is going to happen. Because it does mutate so readily, previous vaccination does not confer protection against the new strain of the flu. Treatment, there's antiviral drugs, amantadine, rimantadine, that are available. There's a fewer class of antivirals termed neuraminidase inhibitors. So Relenza, Tamiflu are ones. The key here is you have to treat within the first 2 days of treatment onset, or of symptom onset typically, because after that, then the virus is on its downward spiral and probably going to go away on its own. Current CDC guidelines highly recommend both zanamivir and oseltamivir as primary treatments in confirmed cases of influenza. Mumps virus. So this is an enveloped ssRNA virus, possesses H, N, and F surface antigens. Droplets of infected saliva. Primarily infects children and adolescents. The primary infection of the ductal epithelial cells in the glands results in cell death and inflammation. It causes acute illness producing unilateral or bilateral swelling of the parotid glands, although other sites such as the testes, ovaries, and pancreas may be infected. Diagnosis: because you have swelling of the cheeks, like your parotid salivary glands are in your cheeks, they swell up so big that it's pretty obvious when a person has mumps. Um, Immunological and molecular tests are available, but usually the physician can just diagnose based on looking at a patient. A vaccine effective in controlling the disease is available. 2 doses are recommended, but there are some emerging cases of mumps vaccinated individuals developing mumps. Measles virus. So measles belongs to the morbillivirus, also known as rubeola. Highly contagious, spreads by aerosol. Initial viral replication takes place in the mucosal cells of the respiratory tract, then replicates in local lymph nodes and spreads systematically. Clinical manifestations of measles virus. The virus circulates in T and B cells, monocytes, until eventually the lungs, gut, bile duct, bladder, skin, and lymphatic organs are involved. After an incubation period of 7 to 10 days, there's an abrupt onset with symptoms of sneezing, runny nose, cough, red eyes, rapidly increasing temperature. 2 to 3 days later, there's a rash that goes all over the body, particularly on the head and trunk. Koplik spots are oral lesions. Here's a picture of Koplik spots. So you'll see these spots forming in the mouth. Appear 2 to 3 days before the rash and are diagnostic. Complications: otitis, inflammation of the ears, pneumonia, encephalitis, inflammation of the brain. Resolution of symptoms provides lifelong immunity. An effective attenuated vaccine is available and recommended for all children. Again, there's cases of measles now that are coming out in vaccinated individuals. Diagnosis: measles is easily diagnosed clinically. Few requests for laboratory identification are made. The virus is fragile, so you got to handle it carefully. Nasopharynx and urine collected only in the early stages of infection. Immunological and molecular tests are available. Respiratory syncytial virus. Members of the genus Pneumovirus. Causative agent of croup, bronchitis, bronchiolitis, interstitial pneumonia. Most common cause of lower respiratory tract disease amongst infants and young children worldwide. Nosocomial infections in hospitals and clinics can cause morbidity and mortality in older patients, often result in pneumonia in adults. It spreads mostly through large particle droplets in contact with fomites rather than through inhalation of small aerosols. The virus may be carried in the nares of asymptomatic adults. RSV infections occur in yearly outbreaks that last 2 to 5 months and usually appear during winter or early spring in temperate zones. Diagnosis: specimen of choice is nasopharyngeal swabs and washes. Using antibody tests, there's rapid detection kits and molecular tests. Normally part of a multiplexed assay for other pathogens. Treatment: ribavirin is a treatment of choice. There's other types of treatments that are available. There is no vaccine for RSV infection.